Right. Hello, everyone. Thank you so much for coming to this talk. So excited to see like quite a full room. I'm Stephanie. I'm at Johns Hopkins. I trained at USC for fellowships, a little bit of PM&R, a little bit of anesthesia. And then I worked for a year at Rancho Los Amigos, where I became a disability advocate. So that's where the origin of this talk is coming in. So why should you care about what I'm talking about? Unfortunately, we don't like to think about this, but our patients often don't feel cared for when they come to see us, especially chronic pain patients. They're really suffering already. And we know this, like trauma plays into so much of our patients' experience. And unfortunately, if you kind of dip into patient forums, healthcare is a huge source of trauma, seeking healthcare. Medical gaslighting is a new term that I discovered the past couple of years, diving into these parts of the internet. And a lot of people with weird presentations feel dismissed, like they're told things are all in their heads and nothing's physically wrong with them, so they should just carry on. But I do believe that pain management can be an inclusive and supportive intervention in someone's life, someone who's experiencing these very tough, unfortunate things. And it's bad luck, it's health, it's just kind of the human experience. So hopefully I can help you see the value of some of this stuff. These are just some memes I pulled off of the internet about medical gaslighting. It's basically, we like to think that patients seek care, they get a diagnosis, they get treatment, they get better. And from people's lived experiences, it's much more complicated than that. People have binders of stuff. And we can all envision that patient who's had to be so on top of things and become a scholar in their own right because of modern medicine's limitations. On the right is a meme of someone knocking on a door. It's a doctor heading into my appointment without reading my chart, getting ready to gaslight the crap out of me. It's like, unfortunately, this is not that rare of an attitude. And here's another meme on the left describing medical gaslighting, just to drive the point home. And then there's still some posts out there that describe good doctors. This patient was saying she met a resident who said she believed her fatigue. She wants to be there to help her. And the patient was so emotional because it unfortunately was a rare occurrence to have a doctor empathize with her like this. And she also asked her to ask permission to touch her walker before she moved it out of the way, which is another kind of thing that we don't think about as healthcare professionals. People consider their mobility devices a part of them. And I think in healthcare, we kind of pathologize instead of consider our patients as whole people sometimes. So what are the learning objectives? I want to try to share how we can establish a collaborative working relationship with new patients in 15 minutes or less, develop a systematic strategy to help patients make informed decisions about their pain management options, eliminate unintentionally offensive or biased language, and minimize healthcare trauma by helping patients feel heard, respected, and cared for. Okay, so general appearance, under 30 seconds, right? We make snap judgments, but let's make them helpful and intelligent of what we're doing in those 30 seconds. We can see how disheveled someone is, or if they're very well put together, how they present themselves to the world, what their mobility is like. Are they ambulating steadily? Are they using a wheelchair? Are they grimacing? Are they guarding a certain part of the body? That gives us so much information already about what could be their pain complaint. The interview, I think you got to be a little generous with this, but the way I make it most efficient is I have people rank from number one, most bothersome or painful, and then going down the list, because oftentimes there's more than one area that's bothersome. You can kind of hit notes of like quality of pain, severity, timing, all the little things in history that you're supposed to get. And then this shows the patient too that you want to prioritize what their number one issue is, and it helps kind of guide the interview because a lot of patients have difficulty organizing their thoughts and describing their symptoms. All the stuff we learned in medical school, inciting events, aggravating and alleviating factors, all very important. But what I really try to get out of the interview too is what have they already tried? How helpful was it? And what are they on right now? Because that way you can quickly determine, okay, there's some things that they haven't tried that you can offer someone. Okay, so audience participation time. Think about your most difficult, complex, challenging cases. Throw out some adjectives. How would you describe them? And it's okay to be honest. I think this is a safe space. Difficult patients, tell me. Frustrating, threatening, gut-wrenching. Yeah, absolutely. Anyone else? Absolutely. I think mental health is a huge barrier to, someone's anxiety can really just get in the way of getting useful information out of the interview. More unwilling, like unmotivated, sure, absolutely. And I think it's not just pain is that it encounters difficult patients. I think all types of people can get in their own way when they're seeking healthcare and they won't realize it. So unfortunately, that lies on us, the healthcare professionals, to really serve as supports and guides to help someone get out of their own way, to collaborate. Any other adjectives? I'm sorry, speed. Yeah, yeah. And it's so hard because that can be so draining as a provider. We want to help our patients with this. But then it also, we also need to protect ourselves as individuals. Like we don't want to get sucked into things. So I think a lot of good adjectives were used. On the right, I highlighted words in red that I feel like are unfortunately quite common. If we don't even say them out loud, they move through our heads. And on the left, I sort of euphemized or try to put a positive, more helpful, descriptive spin on these characteristics. So disabled is not a bad word. I enjoy that word. I think the disabled community is trying to kind of reclaim this. And then, we have used euphemisms like special needs or differently abled. And there's a lot of lack of familiarity with this. And so it often just doesn't get talked about. And I feel like the more we know about it, or the more we realize we don't know, gives us more opportunities to learn and get familiar. Wheelchair user instead of wheelchair bound. In the APP lecture on Thursday, there was a great case where someone was admitting like, hey, I really dismissed this patient. She was wheelchair bound as part of one of the facets. And I was like, oh, wheelchair user. Fat, heavy, obese, let's try high BMI or decreased physical endurance instead, because you're kind of focusing on helping someone with their functional goals and their physical goals. So this is just a little laundry list. Let's see. Frequent redirection I like because that plays a lot into someone's mental health status. And it's like, if you can recognize that someone having a frequent redirection, you know what you can do to help them as opposed to what barriers they're presenting for you and them. If they need cognitive support, if they need simplified summaries, if they are facing housing or financial insecurity, and if they're facing substance use disorder, all of these things are a very positive way to frame someone who's really struggling and it indicate how we as healthcare professionals can help them, as opposed to some less negative, more negative, less helpful descriptors. So those are just some examples that I could think of. Okay, physical exam. We're clinicians, we all know how to do a physical exam, but focusing it on the primary area that's painful, provocative maneuvers, not trying to cause too much pain, but just trying to see like what is really the etiology contributing. Is it muscle, bone, nerves, a combination? And then the assessment, I tried to turn people's number one issue into as specific a diagnosis as possible that you can explain in simple terms. So there's straightforward neuropathic pain, myofascial pain, joint pain, but then there's a little bit more complex centralized pain, like what I like to call, and if there's been an insult to the brain or there's been a history of trauma, I think that heightens the sensitivity to pain. So helping patients understand that quickly is, a skill. You just have to practice. You got to recommend any workup that's needed to further discern etiology or pathology and reassure the patient that there are strategies for their pain management and lifestyle management they probably haven't tried. And you are there to work with them to find a regimen that works with their lifestyle and their goals. So you could probably do all that in less than a minute. And then the plan. So it's really important for patients to understand our plans, because if we throw all these steps at them and they can't organize those thoughts, they can't get your plan isn't as helpful as you think it is, basically. So lifestyle changes, that gives people a lot of self-efficacy. I always give people like, here's some gentle home exercises you can do in bed. It's like, you don't feel up for doing anything today, for 5 minutes, put on your favorite song and, make it fun. And then that helps them feel like, okay, there's something that I can do. My doctor said this was good for me. Let's do it. Medications, I just think simplify, try new things one at a time. And that's kind of my strategy for that. Therapies, PT, OT, and psychology. You need a multidisciplinary team to attack a lot of these complex pain problems. Interventions, again, try new things, one thing at a time. Sometimes less is more. You don't want to flare up a system that's already under stress and really irritated. And also manage expectations that not one thing is going to miraculously fix things. And when patients have that expectation, they're not, they don't have unreasonably high hopes, and they understand that you're there to help be a navigator, a guider in their journey. And then of course, surgery, same thing. So in summary, I like to think that we work for our patients. I always tell my patients, they're the boss. They're like, doc, what should I do? And I'm like, I think these are the reasonable options. What do you like the sound of? We need to show them that we're there to support them and help them find strategies for their most bothersome issues. You know, cures aren't always available. 0% pain, not always available. But if we can get to a manageable level of pain where someone can achieve their functional goals, they want to play with their grandkids, they want to go hiking again, like that's the way to focus things for patients. An inclusive approach to clinical care helps everybody. And so that's my brief stint as a disability advocate for the past 2 years has been, let's have healthcare serve everybody. You know, a lot of talk about racism, bias, ableism, and that's the discrimination against people with impairments. These are all isms that healthcare, unfortunately, you know, we've been a part of the problem. Society has been a part of the problem, but I think healthcare can really be part of the solution moving forward because it should be accessible to everyone. So we don't always have to have all the answers, and it's better to say, I don't know, let's figure this out together, than I can't help you or there's nothing I can do for you. Thank you so much for coming to my TED Talk. If you have any questions, please just find me. That's my email, and my YouTube channel is called Disability Clinic. Like and subscribe.